Yeah.
We are on live, sir. So, good evening. You're on live, sir. So,
Yeah. Yeah. Have people joined?
yes, sir. Good evening. You're on live, sir. Good evening, everyone. So happy to see everyone here in a good evening. And yeah, so today we are here for enlightening our knowledge on arterial blood gas analysis by Dr. Lakshmikant Charan sir. So before entering the presentation, I am very glad to introduce Dr. Lakshmikant Charan sir. He has completed his MD anesthesia from Kasturba Medical College, Manipal, and he has completed his IDCCM from Sundaram Medical Foundation. And sir has also completed European Diploma in Critical Care from Vienna and European Diploma in Anesthesiology and Intensive Care, Barcelona. Sir has also completed his fellowship program in neurocritical care by Society of Neurocritical Care, and he is currently working as a consultant intensivist in Kobe Medical Center and Hospital. Sir has a membership in various councils like Medical Council of India, Indian Society of Anesthesiology, Indian Society of Critical Care Medicine, European Society of Critical Care Medicine. He is also an editor and writer in ISCCM yearbook on monitoring nutrition in critically ill patient. So without any delay, I'll just ask Sir for taking over the session. And before taking over the session, I wanted for all the audience who has been participating in this program, so can just post your question in your YouTube comment box so that we'll discuss it later after the presentation. So the presentation is yours, sir.
Yeah. Thank you, Vishwapal. Thanks for your kind words and introduction. Very good evening to everyone. I think to start with, I'd like to. I'm really glad to present this to this Federation of Clinical Pharmacists of India, and I would like to appreciate FCPA for their efforts in educating the clinical pharmacists to India, and particularly including the critical care module into your education uh, calendar, so that people who are attached to the critical care and ICU setup are used to are having an advantage out of this. And it's really glad to see so many clinical pharmacists really interested in getting educated in the different aspects of clinical care as well, apart from their pharmacological profile. So the next half an hour to 45 minutes, I would like to deal upon the analysis of arterial blood gas. So the importance of this topic and the importance of this particular test is that I myself have been in critical care for almost 15 years now. And if you ask me if there is any one test that I have most commonly asked in the ICU in the 15 years, or to any other critical care physician, the most commonly asked test, or if you ask, if is there one test that I would like to do to know the situation of a patient or the severity of the patient illness, especially if they are in the ICU, it would definitely be an arterial blood gas with one test, and that too a point of care test, which you can get in a matter of 5 to 10 minutes. We get a lot of information in the arterial blood gas, especially for us to know the severity of illness, whatever may be the cause of illness which has caused them to come to the ICU. The severity is very important based on the arterial blood gas and the parameters that you get from arterial blood gas. We can very well know how severe or how sick these patients are, and you can try to triage them even inside the ICU on how to take care of them. So arterial blood gas is very, very important. Over years, we have invented a lot of point of care testings in the medical field, especially in ICU. And this is one of the very, very older machines. It has been in use and it has been in inside the ICU in many of the most of the ICUs nowadays. It is a part of ICU, and people like respiratory therapists, nurses, ICU nurses are educated to use this machine, how to extract a report from this machine. It is very easy, and if it is inside your ICU, you can get the details and this report in a matter of 5 minutes, and you get a lot of information from it, with which you can take care of your patient. So arterial blood gas is very, very important. And analysis of this arterial blood gas is very, very crucial. So to start with, I would like to acknowledge my boss, Dr. Bangi Rajagopalan, who taught me critical care, and I've used many of his slides in this presentation. And my chief, Dr. Eman Shivakumar, for his continuous guidance, and FCPA for giving me this opportunity. So the goal of this talk is to provide an easy and a systematic approach to interpret a blood gas. And the disclaimer is that this talk is not to teach you physiology. This talk is not to teach you the acid-base balance or the other problems of layer of oxygenation and ventilation. All those physiologies are different. I will just try to tell you how, with if you get a ABG report, how easily you can get a diagnosis from the ABG report and how to systematically approach it. So the agenda for the next half an hour is I'd like to give you an overview of what an ABG is, when do you do an ABG, how do you interpret an ABG, and how does an ABG help us in managing the patients in an ICU or any hospital setting. First, what is an ABG? As the name suggests, it is an arterial blood gas. We are doing this, we are getting an arterial blood sample from a patient, and we are trying to see what are all the components in the arterial blood gas, arterial blood, and mainly there are a lot of gases in the arterial blood, like your oxygen and carbon dioxide, and electrolytes, especially your bicarbonate. With viewing all these things, we are trying to get information on the patient's homeostasis or the internal stability. As we all know, human body is a very wonderful created one. Whatever major problems or major insult that happens from the external environment or any disease process that affects the patient's body, the body itself tries to compensate it, or the body itself tries to cope up in managing those external insults. And trying to do all those things, it tries to manage a sort of stability in the patient's physiology. That is called as a homeostasis. So to maintain this homeostasis, there are a lot of things happening inside the patient's body, and a lot of organs are getting involved in this. And one of the main parameters that we use to see to how well this homeostasis is being maintained is the pH. pH is nothing but to be giving in a simple way, pH is nothing but the amount of acidity or the alkalinity or the basicity of the blood. So as we all know, the normal pH of a patient's blood or patient's body should be around 7.4, that is 7.35 to 7.45. That is the pH at which most of our body activities or the most of our metabolic and catabolic activities takes place, and all the organs will work properly only in those range of pH. Once the pH is less than or very lesser than 7.35, it goes into an acidic environment. And if it is more than 7.45, it goes into alkaline. Both are not good for the organ functions. So when it is beyond or less than 7.35 or more than 7.45, definitely your organs are not going to function properly. There is going to be organ dysfunction, and it is, if not addressed at the appropriate time, it can lead on to multi-organ dysfunction and patient mortality. So this is a very, very important thing that is being taken care by your So what we are trying to do in analyzing your arterial blood is trying to see what are all the gases in it, what is the pH, what is the different electrolytes in blood, and how well your body is in the state of homeostasis, or how deranged is this homeostasis. And based on the derangement, you decide on your treatment to bring it back to normal. So this is basically your arterial blood gas analysis. It provides us information about ventilation, oxygenation, and acid base status. All these three are very closely interrelated physiological parameters, which, as I told you, are essential for maintenance of a pH homeostasis. So all this information you can try to get from an arterial blood gas. So what is the process? The first thing is to decide when to obtain an ABG. And once you do an ABG, you should interpret an ABG. And based on the interpretation, you should treat your patient. This is the process in which this testing is being done. So for a proper ABG analysis or ABG management, you need to know when to order it. Order the test only when you need it. It is not only for ABG, for any test for that matter, either in the ICU or in the hospital, whatever blood test or whatever radiological investigations or whatever you ask, you should be needing it. Just for the sake of having that test in your hospital, you cannot go on testing it on the patient. It involves cost. It involves drawing blood from the patient, which can be painful and which can lead on to other problems. So order the test only when you need it. And once you do the test, interpret the ABG fully. Don't see one parameter alone. Go through it fully, interpret it fully every time, and systematically try to interpret. And always interpret the ABG in the context of the patient you are treating. Don't treat the ABG, always treat the patient. See the patient, decide on doing ABG. You have some, at the back of your mind, you expect some problem in the ABG. Only then you can analyze your ABG in a fuller perspective. You see the patient and then see the ABG, and whatever parameters you are getting from the ABG, whether it is correlating with the patient's clinical condition. That is very, very important. Based on that, treat the ABG. Don't stop there. Treat the patient based on your interpretation. Doing a test is not very important. Interpreting it appropriately and treating the patient appropriately based on your interpretation is going to be very, very important. So when do you take a ABG in the ICU or in a hospital setting? As with any test, get one when it will change your management for a particular patient. Do not do it routinely. Don't ask for a routine ABG every day morning. Don't ask for a routine ABG 8th hour or 6th hour. That is not a good practice. Always do a test when you think if there is a problem in that test, you are going to change your management. Don't get one if you will be doing something regardless of whatever is there in the ABG. If you are going to do something regardless of it, do not do that testing, especially an arterial blood gas, because for getting an arterial blood gas, you have to prick an artery. Artery, as we all know, is a very, very delicate structure. You keep on pricking the artery, it can cause bleeding, it can cause hematoma, it can cause thrombus formation, it can cause peripheral ischemia, and a whole lot of problems. And the most important of them is your pain. So whenever you are going to prick an artery, patient will definitely have pain. So before doing a ABG, always think twice whether you are going to really do something different with the ABG interpretation. You may ask me, patients, on arterial line, it is very easy to get a ABG done. So whether we can do it routinely. Even on arterial line, every time you manipulate arterial line, every time you handle an arterial line, there is a very high chances of infection. So unnecessarily do not handle an arterial line. Just because of sake that patient is having arterial, do not do repeated ABGs or a ABG in a routine manner. That will again cause problems. Do it only when you need it. So what are the indications? One is when there are concerns about ventilation, whether patient's ventilation is adequate or not. When you think patient is not awake enough to breathe, like any patients with COPD, patient can come after that. If you do ABG and if you see CO2 to be high, then you think no that it is a COPD causing patient to be drowsy, and you do some interventions like putting the patients on NIP, which can, or if any patient who has a encephalopathy or a drowsiness, do a ABG to see whether to just rule out carbon dioxide as a reason for adaptation. So whether ventilation is adequate or not, whether the pump or the respiratory muscles are functioning properly. Other scenario is when the patient is breathing very fast, like a patient who is asthmatic in a exacerbation, or patient in sepsis with severe tachypnea. In those patients, we need to know when the patient is starting to tire out. These patients can't be tachypneic throughout their life. So till a point of time, patient will try to compensate for all those things by being tachypneic and by trying to wash out their carbon dioxide. But at some point of time, patient might tire. You need to identify that point, and you need to intervene by putting them on a non-invasive ventilator or putting them on a ventilator by intubating. Has to be done appropriately. If you lose that time, patient can go into arrest. Other indication is when you want to know whether oxygenation is adequate. Most of the time we see saturations on the monitor to see the oxygenation of the patient. But in certain scenarios like carbon monoxide intoxication or methemoglobinemia, you cannot rely on the saturation values alone. In those cases, you can do ABG. If you have a co-oximetry, it can give you an indication of carboxyhemoglobin or methemoglobin levels high. Or in a ABG, PaO2 will be definitely a good indicator of your oxygen levels. Next is acid-base balance. As we saw earlier, the pH has to be maintained adequately. Unless the pH is maintained adequately, your organ functions is going to, so your cellular level metabolism is going to be affected. Patients like sepsis, diabetic ketoacidosis, drug overdosage, or when you have a concern about bicarbonate or anion gap being deranged, those situations, we need to know the acid-base balance. When we have concerns about it, ABG is one of the very good tests to identify those problems. And when you start treating these problems, we need to know how good our treatment is. Like in sepsis, when you start resuscitating the patient's acidosis starts to improve. We need to know whether treatment that we are doing is causing an improvement in the patient. For that, the adequacy of treatment and resuscitation can be assessed by doing an arterial blood gas. And the other miscellaneous indications for ABG is after intubating a patient. It is a good practice. Whenever you intubate a patient and put a patient on ventilator, you set up on certain ventilator settings. It is always a good practice to do a ABG at the end of an hour after putting a patient on ventilator. You will know whether the settings that you have done on ventilator is good or not. If it is not good, you can manipulate on your ventilator settings. It is definitely a good. Next is to monitor progression of the disease, as we saw earlier, like in sepsis. In COPD patients, when you put them on a MIB or a ventilator, what we expect is carbon dioxide or oxygenation status improve. That improvement can only be seen by doing a serial ABG. Next thing, as we all know, in recent in the advancement in ABG, now you can get a lot of electrolytes like sodium, potassium, chloride, even ionized calcium levels in ABG. And when you have such doubts, when the patient is having arrhythmia, when you are suspecting a hyperkalemia or hypokalemia, for you to send a potassium to lab and for it to come, it might take a lot of time. In those situations, when it is an emergency, you can do a ABG. ABG, it can have a slight difference in from your lab parameters, but it can give you good information about extremes of values, whether it is very low or very high. Those situations can definitely be used. Next is when you are doing apnea test, when you want to diagnose a brain death, we do apnea test, we see the rise in carbon dioxide, that time we need to do ABG, or we need to decide whether we need to extubate the patient or not. In those situations, we put them on a weaning trials on ventilator, and we do serial ABGs to see how would they cope up with the weaning trials so that we can take a decision on extubating those patients. So these are all the situations in which you run ABG in ICU. So other than this perspective, be very careful whether you really need a ABG or. So once you do a ABG, next thing is interpreting a ABG. To interpret a ABG, again, as we saw in the earlier, acid-base balance is very, very important. As we said earlier, pH has to be maintained between 7.35 to 7.45, as close as 7.4. That is done mainly by two organs. One is lungs, other one is kidneys. These two organs work very swiftly to maintain the pH in a near normal level. So if one system goes out of order, or one system has a problem, the other system tries to compensate for that problem. If lung goes down, kidney tries to compensate. Kidney goes down, lung tries to. What happens when both the organs are affected? Definitely it is a major issue. At least any one of those organs has to be supported by us. In those situations, for lungs, needed ventilation has to be done. For kidneys, if needed, dialysis has to be done. So till that point of time, these two organs try to manage this issue to a certain extent, but it will not compensate to a normal. It will only try to bring it to a normal level. Most of the time, it won't be a bringing the pH to a normalcy like 7.4. It will try to bring it to normalcy. Or if it is brought to normalcy, it is usually a thing that there can be a other disorder as well. So as I said earlier, acidosis and alkalosis is what we are going to see in acid-base balance. It can either be a metabolic problem or a respiratory problem. It is a metabolic problem. Problem is kidney and bicarbonate. If it is a respiratory problem, problem is lung and carbon dioxide. Usually, acidosis is pH of less than 7.35. It happens either by a decrease in bicarbonate or an increase in carbon dioxide. Carbon dioxide is an acid. Bicarbonate is an alkali. So carbon dioxide, when it goes up, acidosis. When it goes down, alkalosis. Bicarbonate, when it goes up, it causes alkalosis. When it goes down, it causes acidosis. So in metabolic problems, what happens is in acidosis, pH is decreased, and it is predominantly because of a decrease in bicarbonate. So what happens? Kidney is affected. Lung tries to compensate by pushing out carbon dioxide. So carbon dioxide is pushed out so that patient's blood carbon dioxide goes down, and this to a certain extent causes alkalosis and compensates for the metabolic acidosis. When there is a metabolic alkalosis, there is increase in pH because of an increase in bicarbonate. So here what happens? Lung tries to conserve carbon dioxide. Patients become less tachypneic, patient's respiratory rate decreases, it tries to retain carbon dioxide and causes respiratory acidosis to compensate for the metabolic alkalosis. Similarly, in respiratory disease, when the problem is in the lung, kidneys try to compensate. If it is a respiratory acidosis, usually pH is less because of an increase in carbon dioxide. So how does the kidney try to compensate? Kidney tries to compensate by conserving bicarbonate. It decreases the bicarbonate loss in your kidney, thereby increases the bicarbonate in your body, causing metabolic alkalosis, compensating for the respiratory acidosis. Similarly, in a respiratory alkalosis, there is loss of carbon dioxide. Because of that, there is an increase in pH. For this, kidney compensates by losing bicarbonate. It excretes more bicarbonate, causing metabolic alkalosis, which tries to compensate the primary problem of respiratory alkalosis. So, kidneys and lungs work on extremes or on different opposite direction to bring the pH close to 7.4. So this is what is very important, and that is what we are trying to interpret in a ABG. So ABG, similar to a ECG, it needs a systematic approach for us to not miss any problems. So this is a normal blood gas that we usually get in a from a ABG machine. So what are all there in it? First is the entered data. These are all data that we enter to the machine, like what FiO2 patient is on, what is in the hemoglobin, and what is the temperature. These things are entered. Next, machine measures certain parameters. So the measured parameters on a ABG are pH, PCO2, PO. These three things are measured by the machine. We need to be very careful. Bicarbonate is not measured by the machine. It is only calculated from these data. So the measured values are only pH, PCO2, and PaO2. And these three values are usually measured at temperature, that is 37. Usually they are measured at this. This is a calibrated one in the machine, and these measured values are done at 37 degrees Celsius. So what we do is patient's temperature is 38.6. There can be some changes in these parameters according to patient's temperature. So what the machine does is it corrects these values to a patient's temperature, that is 38.6. This is temperature correction, and we get slightly different values here. From this measured values, the machine calculates certain things, that is bicarbonate, base excess, and other oxygen related parameters. These are all calculated data. Now we'll see one by one. So these are the components in the ABG machine, usually pH electrode, PCO2 electrode, and PO2 electrode. So there, based on the electrodes, the machine measures these values. So the additional option, there are oximetry is there, which gives you different types of oxygens, like methemoglobin, different hemoglobins like methemoglobin, carboxyhemoglobin, oxygenated and deoxygenated hemoglobin, all those things. And it also measures sodium, potassium, calcium, fluoride, and hemoglobin and other things. So this is some of the recent machines, like one in our ICU gives so much values. There are a lot of things that can come from a single blood sample. So here we need to, they've entered the patient ID, patient's name, patient ventilator mode, whether he's on ventilator or oxygen, how much oxygen, what is the FiO2. All these things are entered. You can enter the peak, tidal volume, peak inspiratory pressure, and minute ventilation. It might not be immediately useful to you, but when you come back to these patients, or when you take these files a little later to assess what was his problem and other things, these things, little things can help us. And values like pH, PaO2, and PCO2 are being measured. And the electrolytes, sodium, potassium, fluoride, ionized calcium, and hematocrit as well as measured. And the glucose is measured. Lactate, this is a very, very important parameter that you get from a ABG. As we all know, lactate is a measure of anaerobic metabolism in the body. When your perfusion is not good, when the organ perfusion is not good, the oxidative metabolism is getting affected. What the tissues does is they go into anaerobic metabolism. Once the anaerobic metabolism increases, the endpoint of anaerobic metabolism, that is your lactate, increases. So high lactate means patient's perfusion is bad. So lactate is a very, very important parameter in ICU perspective. You have a single measurement of lactate if it is high by doing some manipulations. Saturation can be measured. These are the oximetry values. And as we saw, the calculated values like bicarbonate, base excess, and oxygen-related issue parameters can be measured. And the PF ratio as well can be calculated and given to you for you to manipulate on your ventilator parameters, especially in ARDS patients. So coming to the different things, whether temperature correction is important, it was debated for a long period of time, but at the end, what was found is there is no scientific basis, there is no need for this temperature correction, there is no major changes from it. So we are not worried about it. Next, the bicarbonate. Bicarbonate, again, there is something called as actual bicarb, standard bicarb. Again, there was a lot of studies and discussions going on about all these things. Somewhere telling standard is very, very important. Standard is nothing but it standardizes it to a certain parameters. But again, at the end, it is found that actual bicarb is more than enough. You need not standardize it to any PCO2 or anything. Actual bicarb is more than enough. It is almost equal to the standard bicarb, and it can be very well be used for patients' panel. It is usually calculated from the PCO2 value and using a Henderson equation. So base excess, again, base excess is nothing but the difference in the level of base. As we all know, base is nothing but your bicarb. Difference in the base, which is needed to normalize a bicarb. On the normal bicarb, we usually take it as 24. The bicarb is 20. We need 4 to bring it to 24. So that difference is what we call as base excess. That is again being calculated by the ABG. If base excess is on the positive side, it means that patient is alkalotic. If base excess is on the negative side, it means the patient is acidic. Again, standard bicarb and base excess are not found to be very useful. We need not confuse with all those things. Then a lot of the oxygen related parameters like oxygen content, oxygen saturation, alveolar arterial gradient, alveolar arterial ratio around the calculated in the ABG. Again, these are also not very useful. One parameter that can be used in a ICU is alveolar arterial difference. It is usually around 5 to 10. If it is high, it means there is an oxygenation failure. If it is normal, but still patient is hypoxic, it can be a ventilation failure. Let us not confuse with all these things. You just know one thing, patient is hypoxic. You see a AA gradient, that is alveolar arterial PO2 gradient, which is given in your ABG. If it is normal, that is 5 to 10, but still patient is hypoxic, it can be a ventilation failure. If patient is hypoxic with a high alveolar arterial gradient, it means there is a problem with your oxygenation or an alveolar problem. So this is one perspective which can be used to find out what is the reason for hypoxia. And other than that, oxygen content, not very useful. Oxygen saturation, usually we get it in the monitor. If it is a problem like methemoglobinemia or carboxyhemoglobin, then you can rely on the saturation, which is calculated from the PaO2 in a ABG. Other things, as CV said, it's not very useful. So if we remove all those not very useful parameters from a ABG, this is the simple ABG that we get, which is very, very important for everyone. pH, PCO2, PO2, actual bicarb, saturation, PAA gradient, and the FAO. So pH, as we all know, it has to be between 7.35 to 7.45. PCO2, we expect it to be around 40, 35 to 45. If it is less than 35 or for more than 45, there is some problem with your ventilation. Oxygenation, PaO2, usually depends on the FaO2 that patient is getting. Usually we expect it to be more than 60. If patient is in room, it can be maintained around 80 to 100. If it is 80 to 100, it is very good. Oxygenation definitely is not a problem. Bicarbonate, it has to be around 24 plus or minus 4. From 20 to 28 is normal. Less than 20 is acidosis. More than 28 is alkalosis. Saturation, we expect it to be around more than 95 to be good. AA gradient, again, it is usually normal value of AA gradient is based on the age. This formula we can calculate. It is around 5 to 10. So technical errors, it can be there. As a glass syringe, there were problems found, but nowadays we are not using any glass syringes. More heparin can cause disturbance in your pH and PCO2. But nowadays we are getting a A-line syringe. Is a syringe specifically made for taking ABGs. We are using it in many of the ICUs, and it has a specific amount of heparin, and it will not cause any disturbance to the pH or PCO2. If at all you're not having those syringe, take some heparin and completely flush it out. That's very little heparin in your syringe. After flushing it out completely should be enough for the blood to be not clotting till we are taking it to the machine. Again, delay in measurement. Always any investigation has to be done early, especially your ABG. Do not delay it for a long period of. Do not keep the syringe outside for a long period of time. If at all you need some time, keep it in a ice pack. So next, the most important thing: how do you interpret a ABG? So first, to keep it very simple, this is based on some of the steps that has been followed for a long period of time from teaching by my boss, Dr. Andiraj Gopalan. These 7 steps are very essential for the uh, diagnosis of a ABG problem. So these 7 steps, if you do it systematically, it will be very easy for you to diagnose the problems in an ABG. So the first step, as you look into ABG, always look into the pH. pH, as we know, normal is 7.35 to 45. So if it is less than 7.35, patient is acidemic. If it is more than 7.45, patient is alkalemic or alkalotic. So this is the first step. You find out whether it is acidosis or alkalosis. That is the first step. As we know, pH is less than 7.35 is acidosis. It is predominantly caused either by decrease in bicarb or increase in PCO. pH more than 7.45 is alkalosis, and it is caused mainly because of decrease in PCO2 or increase in bicarb. So the next step is, once you find out if it's acidemia or alkalemia, the next step is to find out what is the primary problem. What is the primary organ that is affected, either lung or kidney, whether it is because of carbon dioxide or bicarbonate. So if it is acidemia, as we know, it either has to be bicarb of less than 20 or PCO2 of more than 45. If acidemia and pH bicarb is less than 20, it is metabolic acidosis. If as pH is less than 7.35 and PCO2 is more than 45, it is respiratory acidosis. Again, alkalemia, pH of more than 7.45. If bicarb is more than 28, it is metabolic. If PCO2 is less than 35, it is. You don't get combination of these two things very often. Can be a very rare situation, but predominantly only one of these two things will be a problem. So the first step is to diagnose acidosis or alkalosis based on the pH. Next step is to find out what is the primary problem. This acidosis, see your bicarb, PCO2, decide it is metabolic or respiratory. If it is alkalosis, decide whether it is metabolic. So pH, normal, not a problem. No major problem. Can be a mixed acid-base disorder, but pH is maintained. Should not be a major problem. If it is low, we know it is acidemia. If it is high, we know it is alkaline. Second step in acidosis, see carbon dioxide, bicarb. Carbon dioxide is high, respiratory acidosis. Bicarb is low, metabolic acidosis. Again, alkalosis, carbon dioxide is low, respiratory alkalosis. Bicarb is high, metabolic acidosis. This finishes the second step. Now you find out these 4 primary disorders, whether it is respiratory acidosis, metabolic acidosis, respiratory alkalosis, or metabolic acidosis. This, if you find it out up to this step, it is more than enough for us to know the primary problem. Everything that is coming after this can be a little complex, but that is to see whether body is coping up with these problems or not. This is more than enough for us to diagnose the problem and try to treat it. Now we know what are the causes of respiratory acidosis, metabolic acidosis, respiratory alkalosis, and metabolic alkalosis. So these causes can be further evaluated and tried to treat. So next step is going to see for the compensation. As we know, respiratory needs metabolic compensation. Metabolic needs respiratory compensation, whether those compensations are adequate or not. So the third step is if the patient has a respiratory disturbance, either a respiratory alkalosis or a respiratory acidosis. We need to know whether it is acute or chronic. If it is a metabolic problem, acuteness is not a major issue. There's no major difference between acute. But if it is a respiratory issue, then we need to know whether it is acute or chronic. As we have told you earlier, kidney tries to compensate for the respiratory problem. But again, kidney needs some time. If it is an acute problem, it cannot conserve or excrete bicarbonate immediately. So it is difficult for the compensation to happen in the acute phase. So definitely pH will be very decompensated. If it is a chronic, that is, it has taken more than 2 to 3 days. So the kidneys are slowly trying to compensate for it by either absorption or excretion of bicarbonate. So the pH is trying to be moved to the 7.40 point. So if the pH level of change in pH is not very much, if pH is not very much decompensated in a chronic problem. So how do we diagnose that? How do we know whether it is acute or chronic? See the difference in PCO. Our normal PCO2 is 40. How much the PCO2 is different in each patient? For every 10 increase or decrease in PCO2 from 40, the change in pH, if it is very less, only 0.03 for every 10 PCO2, then it can be a chronic. Kidney is compensating. If the pH change is very much high, that is 0.08 for every 10 change in PCO2, the kidney has not got enough time. So it is an acute, can be confusing. And I'll try to explain it with the examples at the end. You just know these formulas. You need not by heart it. You can have these formulas in empty calc or even in your phone. When you take a ABG, try to use these formulas. Try to see these formulas and try to use them. But the basic concept is the change in pH is high if it is an acute problem because the kidney doesn't have much time to compensate. But the change in pH is less when it is a chronic problem, when the kidney has got enough time to change the bicarbonate. Next step, see if the renal compensation is adequate or not. First, we have seen whether it is acute problem or chronic problem. Now we are seeing whether kidney is adequately compensating for the respiratory problem. Here again, these are all formulas. It is difficult to remember them for all perspective. This is a simple rule, 1, 2, 3, 4, 5 rule, 1, 2, and 4, and 5. Here what we do is acute and chronic. In acute respiratory acidosis, the change in PCO2 for every 10 change in bicarb. That is, for every 10 change in PCO2, what is the change in bicarb? If it is in acute respiratory acidosis, change will be 1. If it is acute respiratory alkalosis, for every 10 PCO2, change in bicarb will be 2. If it is chronic respiratory acidosis, for every 10 change in PCO2, the change in bicarb will be 4. For chronic respiratory alkalosis, again, for every 10 PCO2 change in bicarb will be 5. So 1, 2, 4, 5. It can be confusing, but these formulas can be remembered or it can be seen when the time of interpreting your ABG. So here we are seeing how different or how far our PCO2 is from the normal value of 40. And for that derangement in PCO2, what is the change in bicarb that has happened because of the kidney? If it is good, these compensations has to happen and kidney compensation is adequate. If these compensations doesn't happen, it means his kidney is not able to compensate for the respiratory problem. There is some issues again with the kidney as well. So you need to give bicarb from outside or do a dialysis to manage it. Step 5, step 3 and 4 are for respiratory problems. Step 5 is for metabolic problems. Metabolic problem, again, we know it can either be metabolic acidosis or alkalosis. Here we are not worried about acute or chronic. Here we are directly going to the compensation, respiratory compensation. How good the respiratory compensations are, whether it is adequate or not. These are again formulas which we need to remember. For metabolic acidosis, expected PCO2 is going to be 1.5 into bicarb plus 8 plus or minus 2. It's called as Matrix formula. For metabolic alkalosis, the expected PCO2 is 0.7 into bicarb plus 21%. If you substitute the bicarb value here and you get the expected PCO2, see the PCO2 in your ABG. If it is almost same, it means that respiratory compensations are adequate for the metabolic problem. If they are too much different, it means that the better respiratory compensations are inadequate. Lung is not able to compensate. You need to go ahead and intubate the patient or do something for the respiratory compensation to happen from outside. Next step is only for metabolic acidosis. If it is only metabolic acidosis, as we all know, bicarb is going to be less, pH is going to be less, that you calculate your anion gap. Anion gap is nothing but sodium minus chloride plus bicarb. Usual anion gap is around 12 to 14. If it is less than 12, it is normal. If it is more than 12, it is a high anion gap. As you all know, if it is anion gap is high and metabolic acidosis, the common reasons are methanol poisoning, uremia, DKA, paralytic poisoning, infections like lactic acidosis, ethylene glycol, and salicylate poisoning. Most common being your DKA in ICU. If you have a metabolic acidosis, anion gap is high, always check for the ketones, sugars, and if it is normal, check for the other causes. Last step, step 7, anion gap. If anion gap is high, the change in anion gap and the change in bicarb has to be looked into. If the change in anion gap is more than the change in bicarb, that is the normal bicarb, we all know it is 24. Normal anion gap we take as 12. So the change in anion gap, if it is 14, change is going to be 2. Bicarb, if it is 20, change is 24 minus 20, that is 4. So the anion gap changes 2, but bicarb changes 4. So if anion gap changes more than that of bicarb gap, there can be an additional metabolic alkalosis. If the anion gap changes less when compared to the change in bicarb, it can be a concomitant non-anion gap metabolic acidosis as well. These are all very complex things, but if being a clinical pharmacist, when you start seeing clinical profiles a lot, you need to see all those things. Many of the poisoning can be diagnosed by the metabolic acidosis anion gaps, and many concomitant secondary problems also can be identified when you start seeing this difference in anion gap and bicarbonate gap. So now that we know the 7 steps in interpreting ABG, now you have diagnosed something, how it is useful in our clinical perspective. So as we saw, if it is anion gap acidosis, high anion gap acidosis, you know what are the causes. If the non-anion gap acidosis, the ABG, then see for whether there is any renal tubular acidosis, intestinal loss of bicarb, urethral enterostomy, and some drugs can cause these things. If it is a metabolic alkalosis, again, there are 2 different types. You can start doing tests to diagnose these problems. If there is a hypoxia or hypercarbia, again see the EIA gradient and decide whether it is a filtration or oxygenation problem. And there can be multiple reasons for the problems, and you diagnose them one by one. If it is a respiratory alkalosis, again it can be because of pain, anxiety, severe early sepsis, hepatic failure, or salicylate toxicity. Again, you can test for all those things. So based on these differential diagnoses, you can start evaluating the patient in those directions. So that is the main use of using an ABG. So now I think I have confused all of you to a certain extent. But once you start seeing the ABG day by day, whenever you see a ABG, try to evaluate it systematically, like the 7 steps that I told you earlier. Step 1, 2, 3, 4, 5, 6, 7, each ABGs. Once you start seeing a lot of more and more of ABGs, if you do that day by day, then you will get more used to it, and your ability to diagnose problems for the ABG will be better or easier if you start doing it in the stepwise direction. So to give you some examples, I'll just show you 2 of the ABGs. So this is a ABG. Always before seeing the ABG, know the context of the patient. It is a 60-year-old male smoker with progressive respiratory distress and somnolence. So here, being a smoker, you are expecting a COPD, being in distress as well as somnolent. You are expecting some sort of a respiratory problem, carbon dioxide, involving carbon dioxide, and since patient is somnolent, there can be an recent CO. So this is what you are expecting. Now go and see the ABG. So ABG, step 1, see the pH. So pH is 7.30. So perhaps it is less than 7.35. So it is a acidemia. So definitely there is a acidosis. So the next step, we need to find out what is the primary problem, metabolic or respiratory. Here we expect a respiratory problem. See the PCO2 first. CO2 is more than 45. So definitely it is a respiratory acidosis. See the bicarb, it is 36. So it cannot be a respiratory metabolic acidosis. For metabolic acidosis, bicarbonate has to be lesser than 20. So it is the second step is to identify what acidosis it is. So here we have diagnosed it as a respiratory acidosis. The third step, you need to identify whether it is an acute or chronic. Since it is a respiratory problem, you need to identify whether it is acute or chronic. So here again, start using those formulas for every 10 change in PCO2. What is the change in pH? If it is going to be acute, the PCO2 is 76. The change from normal PCO2 of 40 is 36. So 36 divided by 10 into 0.08. If it is acute, change in pH has to be 0.29. For chronic, 36 by 10 into 0.03. So the change in pH should be 0.01. So if you subtract it from 7.40, expected acute pH is 7.11. Expected chronic pH is 7.30. As you can see from here, if it is a chronic problem, pH is not very much deranged. The acute problem, kidney is not able to manage properly. So problem is pH is very much deranged. So see our pH. Our pH is 7.30. So out of these two, it is matching with chronic respiratory acidosis. So by doing this formula, you identify whether it is a chronic respiratory acidosis or an acute respiratory acidosis. Patient can be a COPD patient, so patient can have a chronic respiratory acidosis. Then you go for compensation using the formula again 1, 2, 4, 5. Here it is a chronic respiratory acidosis, so the compensation has to be change in bicarb has to be 4 for every change 10 change in PC. Using that formula again, you calculate the expected bicarb, it is 14.4. So 14.4 is the change in bicarb that you need. From 24, it has to be in the positive direction. Metabolically, it has to retain bicarbonate to cope up with the respiratory acidosis. So 24 plus 14 is going to be 38. Our bicarb is 36.1. To a certain extent, it is compensating. So it is a pure respiratory acidosis with metabolic compensation. So here again, you can go for the PaO2 and PaO2. PaO2 is low, so there is hypoxia, but AA gradient is normal. So it is predominantly a hypoventilation. So with the ABG, you find out it is a pure chronic respiratory acidosis with metabolic compensation and hypoventilation causing hypoxia. These many changes, you can try to put the patient on NIV or ventilate the patient and try to bring the carbon dioxide down. Your oxygenation will also. Another example, this is a 28-year-old diabetic with respiratory distress, fatigue, and loss. Again, context is a diabetic patient with distress, most likely it can be a diabetic ketoacidosis. In this context, go into the ABG. So first step is to see for the pH. Again, pH less than 7.35 or more than 7.45. It is less than 7.35, so it is going to be a acidosis. Next step for acidosis, you need to find out primary problem, respiratory or metabolic. Here, you are expecting a metabolic acidosis, go to bicarbonate, it is less than 20. So it is definitely a metabolic acidosis. PCO2 is only 34, it is almost normal. So this is not a major problem. Problem is metabolic acidosis. So this is step 2. You have found out what is the primary problem. Next step for a metabolic, you don't need to check if it is acute or chronic. Next step is to find out the compensation. What is the expected PCO2? The Winters formula 1.5 into bicarb plus 8 plus or minus 2. You get a expected by a PCO2 of 27 to 31. Here the PCO2 is around 34. So to certain extent, lung is compensating. So it is a metabolic acidosis. So next step in a metabolic acidosis, you start seeing a anion gap. Sodium is 130, chloride is 100, bicarb is 14. You get an anion gap of 16. So anion gap is more than 12. So it is a high anion gap metabolic acidosis. Here the most common reason can be a diabetic ketoacidosis. So diabetic ketoacidosis, you check the ketones, check the sugars and start treating the DKA with insulin and fluids. If you want to check the bicarb, difference in bicarb is 24 minus 14, that is 10. Whereas difference in anion gap is 16 minus 2, that is 4. So different anion gap is more than the bicarb gap. So there can be an additional non-anion gap acidosis as well. So these many information you can get from a single ABG. Again, start treating the ABG. Doing ABG alone is not enough. So coming to the end, the take-home points that I would like you to have from this presentation is order the test, whatever the test it may be, especially your ABG, only when you need it, not as routine. Interpret the ABG fully every time and do it systematically, if possible, with the 7 steps that I've told you from step 1 to 7 systematically. Always interpret the ABG in the context of the patient. Do not treat the ABG. Do not always treat the patient. Don't stop interpreting the ABG. Treat the patient based on your interpretation. Only then it will be useful. And repeat it at proper interval to see your treatment response. So thank you. I hope given you a basic knowledge about how to deal with the ABG. I'm here to take if there are any questions.
Yes, sure, sir. So thank you, sir. Thank you. Actually, this was an enlightening presentation with arterial blood gas analysis, sir. So I hope most of the clinical pharmacists who works in critical care would be would be a newer topic for them, and even I hope even after this class they'll be able to interrupt with the ABGs for their EC diagnosis or so. We have one question, sir. So one such question is, we have drugs like Diamox, right? It's an acetazolamide, which causes metabolic acidosis, no, sir. So whether this and this acetazolamide involved in anionic gap, so anionic gap acidosis.
No, acetazolamide does not cause anion gap acidosis. It causes acidosis, but it should be a non-anion gap. And anion gap is only a few things like your diabetic ketoacidosis, lactic acidosis, uremia-related things, and salicylate poisoning and methanol poisoning. Other than that, most of them are non-anion gap acidosis.
So one more question, sir. So we do go for means we have rounds again with the intensivist, and before starting the rounds we might get the serum electrolytes level, maybe it delays in getting serum electrolytes level, so that in such situations we'll be going for ABG electrolytes. So how far we can rely on ABG electrolytes when compared with serum electrolytes? How far we could treat the patient based on the ABG electrolytes?
That's what it depends on the machine. Definitely, you need to know whatever machine you have in your department. Try to correlate it with the lab value in 2 or 3 ABGs. Once you do that, you will be knowing whether it is to a certain extent correlating or not. But if not, if it is the what we see in our setup is most of the ABGs, there won't be a major disparity. But all any disparity, it will be 1 or 2. That should not be causing a major issue when you start treating it based on that. But again, extremes of values, always try to check the lab values and decide on it. Other than that, go by the trends and your correlation in day-to-day practice when you start seeing the lab parameters as well. Here we see hemoglobin, sodium, potassium, and all those things in the ABG. When we have a doubt, we send for the lab values and start treating it. But by the time you get back the lab values, you will know whether it is correct or not, whether you have to continue the treatment or not.
Thank you, sir. And one last question, sir. So we do look into normal pH, compensated pH, um, with difference in the PCO2 and bicarbonate level also. So how will you interpret in such situations?
Yeah, it can be a combination of disorders. Some people will have a combination of these 4 are primary disorders, but people can have combination of these disorders. Combination need not be because of the compensation. The compensation usually happens in the opposite direction. But combination of disorders, like one patient with metabolic acidosis as well as respiratory acidosis. Patient with metabolic acidosis ideally has to be tachypnic, he should be pushing out carbon dioxide. That is how the patients usually present to us in a DKA or severe sepsis. When they have a metabolic acidosis, they will push out carbon dioxide and they will try to bring down the carbon dioxide. But what happens is once these patients cross a certain period of time, they start tiring out. Once they start tiring out, what happens? They will become less tachypnic. That period of time, again, they will not be able to push out the carbon dioxide. Carbon dioxide also will be going up. Bicarbonate also will be down. Carbon dioxide also will be going up, and your pH will not be compensated. Here, there will be a combination of metabolic acidosis as well as respiratory acidosis. That is, these scenarios are very, very important for us to identify in ICU. In a patient like bronchial asthma with a severe exacerbation who come in a respiratory distress, or in a sepsis patient who come in with a distress, or a DKA patient who come with a distress, we expect a low PCO. A normal PCO2, like a 35 or a 40, is not normal in these patients. Just because PCO2 is 35 or 40, do not wait. It means that patient is tiring out. Ideally, these patients should be having a PCO2 of around 25 to 30 to compensate for the primary problem. If it is not, if the PCO2 is even normal, you need to suspect that patient is tiring out. You need to start supporting the patient, either by putting them on a NIV or intubating them early. If you allow them to further tire out, they can have a respiratory arrest.
Thank you, sir. Thank you so much for enlightening us. And thank you, everyone. Thank you, everyone, for joining us with the wonderful session by Dr. Charan, sir. And we hope we'll meet again in further upcoming slides. Thank you.
Thank you.